Hi, everyone. I'm Lisa Kleins, Director of Education for Dr. Brown's Medical. Thank you to Feeding Matters for inviting us to be here today. And today I want to talk about something that's important to all of us, and that's improving long-term feeding outcomes for our fragile feeders, especially our NICU babies. The Feeding Matters community, this number may be no surprise to you, this 42%. 42% of NICU infants have later feeding problems such as food refusal, oral motor problems, poor acceptance of textured foods, coughing or choking, or prolonged feeding times. And those of you who work in outpatient know this very well, but also as parents and caregivers, this is real for you. You are not alone. And at Dr. Brown's Medical, our goal is to get that number down. We know that traditional feeding practices and products can contribute to these poor feeding outcomes. That's why our mission is to deliver valuable feeding solutions to help provide the best possible feeding outcomes for all babies and all families. And we support this feeding together. I'm sure we can all agree that the only way to move forward is with providing the best possible outcomes for all babies is together. And how can we do that? So the first is with a supportive feeding culture. That means we're all working together to move from a volume-driven feeding culture to an infant-driven, where the infant and the family are at the center. Also is having evidence-based feeding products and evidence-based feeding practices, along with the education and support that we need, the ongoing education and support that yields improved feeding experiences and improved parent and staff satisfaction and consistent messaging. So let's discuss today. Let's look at some of those things that we want to have in our feeding together model. And as you're thinking about, I want you to think about why you're using the feeding products and practices you're using. Think about specifically, is there evidence behind these practices and products? Are they safe? Do you know that what you're using is safe for each and every baby? Can these products be used nicely from hospital to home? Can the parents purchase them easily when they go home? Are they consistent? Are the methods you're using, the practices, consistent throughout the unit for a practice, or the products? Do the products deliver consistent flow rates or consistent experience for these babies to protect their most vulnerable brains? And if you're in a hospital or in a early intervention situation, when you provide information or when you provide these products to parents, can you explain why you've chosen a specific bottle system for them? Okay, to help you answer these, we want to provide you with three areas that you can look at, three products or practices that can contribute to feeding success. And one is the Dr. Brown Zero Resistance Bottle System, our consistent, reliable nipples that have nipple consistent flow rates, and then also the standardized evidence-based infant-driven feeding program. So let's first look at our zero resistance bottle system. What is zero resistance? So this isn't a fancy term. This really explains zero resistance is about what's happening inside the bottle and how that affects what's delivered to our babies. So if we look at a typical bottle system, this bottle here on the left, this is a typical disposable bottle system that's used often in hospitals. And when the baby starts drinking from this, there is negative pressure that occurs within this bottle. This negative pressure is resistance. It makes it harder for the baby to drink from the bottle, which can cause weight loss. It could cause aversion, exhaustion. The baby's not as efficient. In contrast, because of the internal vent system, this green internal vent system that you see here, the Dr. Brown Zero Resistance Bottle System, there is no negative pressure. It eliminates all that negative pressure, so the pressure is always positive. There is no resistance. So this supports efficiency, endurance, successful feeding experiences. Resistance makes it harder for babies to feed. So why in the NICU, when we have these babies who are already compromised, would we want to have these unnecessary challenges. So I want to look a little bit about what this might try to make it applicable to all of us. Let's look at this video of a swimmer. So this swimmer is swimming very easily, right? There's no resistance in the water. It's pretty smooth. The water is very smooth. There's good form. The water doesn't have is not overwhelming or challenging. They're using good skill, so they're developing good skill. And I bet this swimmer could do this again, right? And so if we said to the swimmer, hey, how was it? They'd say, it was good. It felt good. I'd be happy to do it again. And it was a positive experience. In contrast, let's equate this to what we would think that possibly this swimmer is experiencing and with some resistance. So we're going to, the previous one that I showed you was what we would say the Dr. Brown's bottle system is. So the swimmer without resistance would be the Dr. Brown's bottle system. In contrast, this one would be what would happen if we use a bottle with resistance. So that disposable bottle or other bottle systems without the internal vent system. So let's take a peek at this swimmer. So this swimmer is swimming against the current. The current adds resistance. So this is what is similar to what other bottle systems do with negative pressure and resistance. Think about the form. The swimmer is flailing about, right? And not good form. If they're not using good form, they're not using good skill and not learning good skill. This swimmer is also probably getting exhausted. Probably couldn't go as far. They're not getting as far because they're swimming against the current, and not as efficient. And I bet that this swimmer is very exhausted after swimming. And would you want to do this every 3 hours? Similarly to a baby who's feeding and working hard, if we said to this swimmer, was this a positive experience? They may say, oh my gosh, that was so hard. I never want to do that again. So just to summarize what we've talked about a little bit, this negative pressure causes increased energy expenditure. It's harder and it has reduced feeding efficiency. So the baby might not be able to take as much because they're getting exhausted. And because the baby must exert more energy to extract, to get that liquid out of the bottle, this negative pressure can also lead to reduced physiological stability. So they might have some desaturations or some reduced heart rates. And this negative pressure is also the reason why that the nipple might collapse during a feeding. It's the negative pressure within the bottle system. Nipples with that internal vent system do not have that negative pressure, and you may have seen this in your own practice. So we have the bottle system, but of course on every bottle system, if we're using bottles, we have to have the nipples. So the nipples are not equal either. And what we know about disposable nipples and other nipple systems is that they are very inconsistent in their flow rates. So evidence has demonstrated that other nipples are inconsistent in nipple flow rates. This means when you select a disposable slow flow, you cannot be guaranteed of the flow rate. Now, what do I mean by that? It means if we line up 10 of these nipples and test the flow rates of each one, they may be different every time. In fact, there is a nurse researcher named Dr. Britt Patos, and she's done extensive research on these nipples, documenting that they're not consistent in the flow rates. And actually, in one of her articles, she says that their use in the NICU should be reconsidered. Reconsidered. So why are we still using these with our fragile feeders or with any baby in the hospital or NICU, actually? So if a nipple doesn't offer the flow rate that we expect, this is not safe, right? So for example, if you are working with a baby and know that they need a very specific flow rate in order to have safe feeding, so they maybe don't have reduced coordination or don't aspirate, if we know they need that flow rate, but we continue to use those nipples and grab one from the stock, it might not be that flow rate. You cannot guarantee the flow rate, and this is not safe practice. Alternatively, Dr. Brown's, the Dr. Brown's bottle systems and the nipples have consistent precision manufacturing that are quality controlled nipples, and they are consistent and reliable. And consistent, reliable, and safe should be the only option. And at Dr. Brown's, we do have a variety of choices in providing just the right nipple flow rate to match every baby's needs. And just to be clear, flow rates are not meant to be a progression. You know, these are shown here in a line, but babies are meant to be fed with whatever flow they need, whatever skill they have that matches that baby's each individual need. When it comes to fragile feeders requiring just the right flow rate, our slow flow nipples are all tested individually to ensure that the flow rates are safe and consistent. So the zero resistance bottle system, along with the Dr. Brown's quality controlled, dependable nipple flow rates, together are the perfect solution. And then we do, when the baby skills advance, if they show signs that they're indicating and they maybe need a faster flow rate, we do have 8 flow rate options. So overall, you can custom fit the appropriate flow rate to match every baby's individual developmental skill level. So we talked about inconsistencies in feeding products. We also know that feeding practice and feeding practices in the NICUs have been inconsistent, and this is documented in research. Previously, it's been documented that practices vary from nursery to nursery, from caregiver to caregiver, and from provider to provider. How frustrating this must be for parents, staff, and most importantly, the babies. If we think about what a baby would say if they could talk, when people are feeding differently with different products, with different practices, that must be very frustrating for babies. And remember, they're at this time when their brains are just soaking up all that information and they are learning about feeding. And what they learn about feeding is going to be with them forever. So recent research has actually shown that there are a wide varieties in methods in cue-based, especially even in breastfeeding. There's a research study that showed that globally there's a wide variety in how we're responding to cues when babies are breastfeeding. And then another global survey of oral feeding practices in 2025 article revealed significant variability in feeding practices. So we know that this is still a challenge and it's something we need to address. What are these inconsistent feeding practices? So for example, we might have inconsistent documentation. Historically, people have charted things such as what does feeding look like? Good, fair, or poor? Well, what does good mean? Good to me might mean something different to a nurse who's feeding the baby and might mean something even totally different to the provider who's reading the documentation in the chart. So documentation has been inconsistent. Also communication, how we talk to each other, the language we use is not standardized. In the NICU, maybe how we progress from oral feeding or NG feeding to oral feeding, all of that communication between the staff and what we're communicating to the parents might be different and inconsistent. And also we've had inconsistency in feeding strategies. Are we using the same strategies? Are we using the same words for strategies? And do we all even agree that the same strategies are effective and should be used with our NICU infants? So all of these inconsistencies result in confused staff and confused parents and really confused babies. And unfortunately, they can't verbally tell us, but they do tell us with their cues, of course. So often in units where there's no consistent feeding program, parents are told different things related to feeding by different staff members. This is not the end of the story. The Dr. Brown's Medical Infant-Driven Feeding Program can be a part of your solution. So IDF is an online learning for all staff. It's an online learning program you take on your computer. A hospital purchases this for their whole staff, their whole unit takes it, and it's 4 hours of education. And the best part about infant-driven feeding is it's not just, this one little chapter. It is a complete solution to change your feeding culture. And it includes a neurodevelopmental foundation. So we have the basics of the sensory processing, early feeding experiences. There is a large portion of infant-driven feeding that focuses on providing positive feeding experiences from the beginning. So we like to say that feeding doesn't start with breast or bottle feeding. It actually starts from day one. And there are so many things that parents and staff can do to help promote positive feeding experiences for babies. Remember, this is the time they're learning about feeding. So we have to set the stage from day one. So IDF provides that information and helpful tips for how to provide positive feeding experiences that the staff and the families can do from day one. IDF also identifies a process from how to go from NG feedings to full oral feedings, and it's a documented process. It is hugely includes families. Families are key to infant-driven feeding. Families are going to be the ones taking the babies home, and it's essential that they learn about their baby's cues. And it also includes, IDF includes breast and bottle. It's not just about bottle feeding, it is about feeding. So breastfeeding has a huge component as well. And another great aspect of IDF is that it's not just the learning, but it is also a few chapters on how to create this change in your unit. So it's about systems change and how to sustain the practice and get everyone on board so you can implement this in your entire unit. So while IDF is a program that many hospitals complete unit-wide, it's also an excellent individual learning opportunity for a single user for anyone who feeds fragile infants or after the babies even leave the NICU. We have many individuals who are in early intervention that have taken IDF. It provides benefits for those working in that outpatient setting to also learn more about the sensory experiences and the neurodevelopment of the premature infant. So with the infant-driven feeding program, these inconsistencies become consistent. We now have consistent documentation, consistent communication, and consistent feeding strategies. So, for example, with consistent communication, the infant-driven feeding program also includes 3 scales: the readiness scale, the caregiver strategy scale, and the quality scale. And these scales are validated and are evidence-based to put everyone on the same page so we're all using the same documentation and the same communication with all staff, and gives us a language that we can communicate with families as well. So eliminating consistency is key. That is one of the huge benefits of infant-driven feeding. There are also other outstanding benefits for the use of the infant-driven feeding program, and there have been several QI projects and published papers that document these. These benefits are reduced time to full oral feedings, reduced length of stay for our hospitalized infants, increased breastfeeding rates, and increased skin-to-skin time. And a recent study showed not just increased breastfeeding rates in the hospital, but also after discharge and 6 months after when the babies go home. Improved nursing satisfaction and improved parent satisfaction. And an additional, more recent study by Bloom et al. Showed that there is also fewer referrals to feeding therapy after discharge. So these babies are having better outcomes long term, which again goes back to our goal of reducing the 42% of NICU patients have feeding problems later on. So as we wrap up, I want you to ask again, I want you to consider again, why are you using the feeding products and practices you do? Are they evidence-based? Do they promote safety? Do they support the families from going hospital to home? Are they consistent? And do you know why? Can you explain that to parents? So for the professionals looking to make the switch to use your products and practices that have all those components, you might want to consider to learn more about making the switch to Dr. Brown's Medical and the Zero Resistance Bottle System and the Infant-Driven Feeding Program. And this code here is some information about how to make the switch to Dr. Brown, so feel free to scan that. And then for parents and caregivers, parents can continue to support safe, consistent, and positive feeding experiences following discharge to home. All bottles and nipples are available for parents to purchase. And you can find purchasing information for parents and caregivers in the US and Canada on our website, or you can scan this QR code as well, or feel free to reach out to us to learn more about the specific, where to find these specific products that the families that you serve, where they can find them. You can reach out to us at our website is here, as well as emailing us at medinfo@drbrownsmedical.com, or for infant-driven feeding specifically, idfinfo@drbrownsmedical.com. Thank you so much for being here, and I look forward to chatting with you all soon. Thank you, and bye-bye.